So we are really thrilled to welcome Dr. Doug Robinson to speak with us tonight on a very important topic that I think that we all need to understand more about. Dr. Robinson is an endocrinologist and diabetes specialist who recently retired from an almost 30-year career with Atrium Health at the Charlotte Medical Center in North Carolina. Shout out to North Carolina. Before that, he had served 10 years as a medical officer and endocrinologist in the Navy, graduated from the University of Pittsburgh School of Medicine, and holds a doctorate in biochemistry from the same school. He is a volunteer physician at the Good Samaritan Clinic in Morgantown, North Carolina, and is a healthcare activist and current chair of Healthcare Justice North Carolina, which is a chapter of the Physicians for a National Health Program. So, Dr. Robinson, I'm going to spotlight you and let you get going. There you
Hi.
go.
Thank you for that nice introduction. I'm going to turn off my video and then share my screen. All right, there we are. So, thank you for inviting me to be with you tonight. I'm excited to talk to you about um, Medicaid cuts and medical debt, and then the cause of that, which is healthcare in America. So I want to first mention my organization as I said, I'm current chair of Healthcare Justice North Carolina. We're one of three chapters of Physicians for a National Health Program in North Carolina. And PNHP has about 25,000 members, including physicians, healthcare professionals, students, and laypersons. And we're all advocates for a universal, comprehensive, single payer national health program in the United States. We'll be talking about that more at the end. If you're interested in PNHP or the work it does, or want to become a member, you don't have to be a physician to be a member. Scan that QR code. And I'll have a number of QR codes throughout the presentation for you. So this is a picture of Lake James in the foothills of Western North Carolina, where I spend most of my time. And I'm using it to serve as a reminder that I really want to frame tonight's talk in terms of the lesson from a story that's called the River Parable or the River Story that I think many of you are probably familiar with. And that lesson would say that while addressing urgent and immediate downstream issues of people drowning in medical debt or at risk of dying from lack of health insurance, that it's very important to look upstream and determine why people are ending up underwater in the first place. And in this case, of these two issues, it's our American healthcare system. Some would call it overly expensive, complicated, dysfunctional. Others would call it just plain broken. Um, it's you know we're just to be clear, we have exceptional healthcare in the United States in a number of good ways. Our technology, our innovation, cutting edge treatments are some of the best in the world, but we're exceptionally bad in far too many ways. We're the only wealthy nation that doesn't provide universal health care. Our healthcare costs more than other wealthy nations by twofold, almost $15,000 per person per year. And yet we have some of the worst outcomes in healthcare, particularly with regard to life expectancy, infant mortality, maternal mortality, Black maternal mortality, all at the bottom of other comparable wealthy nations. Then we do a couple of funny oddball things in our country. We treat healthcare as a market commodity, like you'd treat eggs or gasoline. I've yet to see somebody comparison shop when they're on their way to the ER having a stroke or a heart attack. So it doesn't work as a market commodity for a number of reasons. And then we link our healthcare to employment. So if you lose your job, you lose your health care. What could go wrong with that? I'll talk in fairly stark terms this evening about death due to lack of insurance. And turns out, insurance doesn't guarantee a healthy life, but it's important for access to healthcare, and healthcare is necessary for maintaining good health and living a long life. And an estimated almost 70,000 of us die each year simply because we don't have insurance. And then finally, the way we train physicians and the way they're deployed around the country is kind of backwards. We're overly focused on disease treatment rather than prevention. This next slide is from the Commonwealth Fund, and it's the 2024 statistics regarding insurance status of working age adults. And you can see that 56% of us are insured all year. 9% of us are uninsured. That's about 27 million of us don't have any health insurance. And there's this 12% group where there's a gap in insurance during the year. I can tell you as a doctor, that's not good. If you're undergoing cancer treatment or you have a chronic illness, you don't want a gap in your insurance. And then I really want to direct your attention to this last group. If you're unaware of the term underinsured and what that means. So from an academic standpoint, underinsured would mean you spend more than 10% of your household income on out-of-pocket healthcare costs. And that's things like deductibles, co-pays, co-insurance. Doesn't include premiums. But if you're spending more than 10% of your household income on that, you're really underinsured. Or if you're spending more than 5% of your household income on deductibles. We all know what that feels like beginning of every year when you go to the doctor's office and you get the complete bill and you go, oh, that's because my deductible hasn't finished up yet. So it's like having no insurance. Now, the other interesting thing about this is 2/3 of this group actually has employer sponsored health insurance. You think that would protect you from being underinsured, but actually most of these folks have employer-sponsored insurance. The ACA, the marketplace insurance was wonderful at increasing the number of insured persons in the United States. What it did do as well is it increased the underinsured population. I don't know if you know anybody who has marketplace insurance. My daughter does. She has a bronze plan. Her deductible's about $7,000 a year. So she doesn't get any insurance until she's paid $7,000. So that's underinsurance. Another graph, I think this is from the Commonwealth Fund as well, and this looks at healthcare spending as a percent of GDP compared to outcomes, access to healthcare, equity, and health outcomes. And you can see we spend more than any other wealthy nation on as a percent of GDP on healthcare, about 18%, and we rank at the bottom outcome-wise. Not good. We don't get much for our money. Well, where does our money go if we're not getting good health care for it? Well, we spend about $4 trillion in healthcare in this country yearly. About 34% of that goes to administrative cost. So most healthcare for adults in the United States is provided through private health insurance companies, for-profit health insurance companies, and they have high administrative costs. And then because health insurance is so daggone complicated in the United States, there's about 1,000 health insurance companies. Now, the Big Ten do most of the health insurance, but there's a bunch of health insurance companies in the country, and they make billing and documenting very complex. So hospitals need huge billing staffs, and physicians need extra office staff to help with that. There's about 10 administrators in the United States per physician, which you don't see in most other countries because of the complexity of our crazy insurance system. Where else does the money go? Well, it goes into pockets, and we know this. Now, this is 2022 data, so it's probably even higher now. We have billions and billions in profits going to the big five health insurance companies, and millions going into as compensation to the CEOs. So they are doing well. So all this cumulative evidence has really lowered the opinion of healthcare and quality of coverage in the United States. We're at about a 20-year low in the way people feel about not only healthcare, but healthcare coverage. Both are below 50%. So that's the landscape of healthcare and healthcare coverage in the United States. I'll come back to that at the end to talk about how we can fix that. But now I want to talk about a couple of byproducts of our American healthcare system. And the first is medical debt. Lots of us have medical debt. 100 million Americans have medical debt. We owe about $220 billion. 3 million of us over $10,000. And we borrow to pay off medical debt, 74 billion in borrowing in 2024. Half of adults can't pay a $500 medical bill without going into debt. So if you have high deductible insurance, there you go. You're in medical debt with one big old medical bill in the beginning of the year. Debt has its consequences. It actually physically results in worse physical and mental health for people who have it. People with medical debt skip or postpone health care due to cost. Drug costs prevent, a fifth of us from filling prescriptions. We've all had that shock moment where you go to the pharmacy and the person behind the counter says, "Did they tell you how much this is going to cost?" And then they tell you. A lot of people walk away when they're told that number. When you have medical debt, you have trouble paying your bills, affording basic necessities. You might have to take a second job. You're not going to buy a home. You're not going to go on with that education. It causes two-thirds of the bankruptcies in the United States, and it destroys credit scores, and it really shouldn't. More about that in a minute. So this is a study that was published in my home state of North Carolina by Duke Law and North Carolina Treasurer back in 2023, looking at hospitals suing patients over a 5-year period, about 6,000 lawsuits against 7,500 patients. And I'm not showing you this for more data. I just want to show you some quotes from the folks who had judgments against them, and they're very telling. This person talks about anxiety and stress aggravating illness. This one, scared to go to the doctor because didn't want to incur any more charges. And this last person, judgment of almost $200,000, went through everything to get help on the bills, and they just said no. Who has medical debt? Young adults, people of color, women, all more likely to have medical debt. To be clear, most of the debt I'm talking about here is hospital incurred medical debt. It's more common in the 10 southern states that didn't expand Medicaid, as you might expect, low income persons, persons with poor health or a disability. So imagine you're sick, you're fighting a health condition, you're disabled, and you're getting hounded for medical bills. That shouldn't go on in this country. And then, of course, the uninsured. This is an important point. Half of the people with medical debt have health insurance. You would think that health insurance would protect you from medical debt. It doesn't. This is one group of people who are really prone to medical debt, and it's a tragedy. So, and I think we all probably know somebody like this. These are young families incurring medical debt from childbirth. So, 12% of people with medical debt attribute it to pregnancy or childbirth, and having a baby doubles the risk of medical debt. Um, Patients with health insurance, even with health insurance, average another $3,000 in medical bills. ICU stays are expensive. So when these young families have all this medical debt coming out of a pregnancy, they do what any of us would do. They cut back on spending on food and clothing. They don't buy a home. They delay education. They probably delay having another child. So it really changes their life. Well, why do we have medical debt? I'm going to repeat it again. It's our healthcare system. People don't have insurance or they're underinsured. Our healthcare is expensive. Our prescription drugs are expensive. There's a lot of skimpy health insurance plans out there that don't provide comprehensive coverage, high deductibles, and then insurance companies deny and delay care. Saw this a lot when I was a practicing physician. I'd prescribe a certain course of treatment for a patient, and the insurance company would deny coverage for it. And then it's such a complex system that billing errors are rampant. So just circling back to underinsurance in working adults, this is North Carolina data now, but it's pretty close to national standards. So if you look at the left-hand side of the slide, we're looking at an employer-sponsored plan for a single person in North Carolina. Scan down and you see that they're spending almost 6% of their average or median income, rather, on their deductible. You remember, I said over 5%, that's underinsured. So your average employer-sponsored single plan person in North Carolina is underinsured. And we see that in 23 other states, they're underinsured. And then if you add up deductibles and premiums, family plan, most people with family plans are underinsured too. And then the ACA, as I talked about. I got a little, I discovered that you could make slides with artificial intelligence. And this is a little bit before I reined it in. I think I had a couple of Starbucks and got on AI. So I want you to ignore a lot of things except here, where a medical bill turns into bad debt and then goes into collections, where some hospitals will actually sell that debt for pennies on the dollar, and then the debt buyer will try to collect it. And then about 3 years ago, all the major credit reporting firms decided that they wouldn't put this on your credit report until you had held it for over a year. So if you have medical debt over $500 and it's been sitting in collections for a year, it can certainly end up on your credit report and do tremendous amounts of damage for your ability to, buy a car, buy a home, what have you. Now, I do want to make one point about medical debt here. It's not like credit card debt or personal loan debt. It's just not a good indicator of a person's credit worthiness, because it's unexpected, right? It's often due to emergencies or acute care treatment. And as I said, if it ends up on your credit report, that's going to interfere with your ability to get a mortgage, an auto loan, employment, and it really doesn't deserve to be there. So there have been some federal policies addressing that. In 2025, the Consumer Financial Protection Bureau was supposed to have a rule that was going to be implemented that would ban medical bills on credit reports. Unfortunately, that rule was vacated by a federal court. So your medical debt is still going to end up on a credit report. While we're still on the subject of federal policies and medical debt, the 2022 No Surprises Act was helpful. This eliminated what's called balance billing. This means, I'm sure you've heard of this, you go into an emergency room that's in your network, you think you're doing right, but the ER doctor's not in network, so you get a balance bill from that guy. Or you're in the hospital, but the radiologist isn't in network, so you get an extra bill from that guy. So this eliminated that balance billing. And then down here it says if you're uninsured, you can get a good faith estimate. So that's important. I always thought that was a little weird that only if you're uninsured can you get a good faith estimate. Obviously, I think everybody ought to be able to get a good faith estimate, but healthcare isn't transparent in the United States. And then, as part of the Affordable Care Act, they really wanted nonprofit hospitals. About 5,000 hospitals in the United States. I think about 60% of them are nonprofit or not-for-profit hospitals. They wanted them to create and implement a written financial assistance policy. So that's what the feds have done. It's not a lot, and it's getting less. States have probably done more. They've strengthened financial assistance requirements. They're holding not-for-profit hospitals more accountable. Not-for-profit hospitals are tax exempt and get a lot of benefits of being tax exempt. And for that, in return for that, they're supposed to reinvest back in the healthcare of the community. And states are now requiring some of these not-for-profit hospitals to do that. Some hospitals and governments have partnered with charities like Undo Medical Debt, that I'll talk about in a minute, to purchase and cancel debt. And then there's been strengthening of consumer protections. And then in North Carolina, a real success story here was we've used higher Medicaid payments to hospitals to allow them to relieve medical debt in exchange for those payments. This is probably the most important slide, is what can people do? Well, you got to do your due diligence, do your homework, ask questions, don't take no for an answer. Um, we're probably better at taking our car to the mechanic and asking questions and than we are when we're sick and we go to a hospital or the doctor. So you really want to know your insurance coverage, out-of-patient costs, make sure your providers are in network. Then there's this little thing of facility fees. And I put this in here because this just came up the other day for a family member. Hospitals now, and this is growing, issue. Hospitals will call outlying facilities that aren't attached to the hospital, maybe miles away, a hospital facility. And so when you go there to get your colonoscopy or physical therapy or whatever, you'll be charged an additional facility fee, even though you're getting no added benefit from being at that hospital facility than you would be if you were down the street at a non-hospital facility. So ask about that up front. Ask about facility fees. Get public insurance if you qualify. Um, again, if you're uninsured, get a cost estimate. You want to check into financial assistance, and then this is hard work. Take a fine tooth comb to your bill. You can ask for line items for every cost, for every service and prescription. They have to give you that. Negotiate with the hospital directly. And then most important, never, ever, ever use a credit card to pay a medical bill. It really it eliminates your ability to get charity care and go on a payment plan. Hospitals won't negotiate with you. They got a higher percentage rate. Um, Shockingly, some hospitals work with credit card companies and encourage you to put your medical debt on a credit card bill. Don't do it. So if you're already in debt, ring collections, don't give up. You can still try to qualify for charity care even after the fact. Dispute your bill if it's inaccurate. Contact free legal aid if you feel you need that. Most importantly, do not ignore the issue. So a couple of charitable organizations here I want to finish up with. Sometimes it's hard to figure if you qualify for financial assistance, and this is a nonprofit called Dollar For, which will help you figure out if you qualify for financial assistance, depending on the assistance programs, income, and eligibility requirements. Go ahead and scan that QR code if you're interested in learning more about Dollar For. Really, very, very helpful organization because it can be hard to tell if you qualify for financial assistance. And then I want to stress this organization. What a great charitable or group this is. Used to be called RIP Medical Debt. I guess they thought that was a little too harsh. I loved it, but they changed it to Undo Medical Debt a couple of years ago. This was founded in 2014 by two debt collectors who really wanted to help those in need. And their idea was to buy up large bundles of delinquent medical debt, just like debt buying groups do. But instead of going after patients to pay it back, they paid it off for typically a penny on the dollar. So they've paid off $15 billion in medical debt for almost 10 million people since they were founded. They partner with hospitals and governments. Scan that QR code and take a look at them. They're a wonderful charitable organization. They'll partner with your church. They'll partner with government entities. Sometimes they'll partner with hospitals. It's a terrific organization that's done good work. Again, wish we didn't have to have organizations like that, but in our American healthcare system, which creates medical debt, we need that. I want to end, I've shown you a lot of statistics, a lot of numbers. I want to end with a personal story of a local North Carolina resident, a great guy, Terry Belk, and tell his story about how he handled medical debt. Spoiler alert, he eventually ended up with his story on NBC News. And the day afterwards, the hospital system said they were not going to put a lien on his property anymore. So this is Terry Belk from North Carolina.
I watched my wife die, and these people still came at me and her as she was dying. for money we didn't have. Not saying we didn't owe it, but it should have been a better way to collect it than what they were doing. This is a national crisis. This is not just affecting North Carolina. This is nationwide, and hopefully this becomes a movement. My late wife was diagnosed with breast cancer in 2003. We had private health insurance, but it wasn't adequate to cover all the bills. So we were shocked a few months down the road, we get this big gigantic bill from the medical providers saying that we owed $23,000 that the insurance company didn't pay. About a month and a half, we get these letters and phone calls from their attorney threatening to take us to court, to sue us, put a judgment on us and all of that. She said, why are they doing this to us? To us, that's a lot of money, but to them, I'm sure it was pennies. And several months later, she subsequently passed. Fast forward in 2010, I was diagnosed with prostate cancer. I had private health insurance there again, and it wasn't adequate to cover all the bills. I'm paying on the prostate cancer bill, and I am probably going to take this debt into the afterlife. The only way that this is going to stop if people speak up, speak out, and advocate for better. I'm in this because I lost love of my life. And I feel her spirit with me every day, and I know that she wants me to stay in this fight, and I will.
All right. So every time I've heard Terry's story a number of times. I've met him, as I said, just a couple of months ago. He's doing very well, but he's still an advocate and speaking out against medical debt. Terrific guy. Let's pivot now to another byproduct of our broken American healthcare system, and that's healthcare insecurity. The fact that some people can have their health insurance and healthcare and ability to have access to care and a healthy life taken away from them. So we're going to be talking about the effects of the One Big Beautiful Bill Act, or I'm going to refer to it as OBA, throughout out here. And now, as you recall, that OBA increased the federal deficit by about 3.4 trillion over the next 10 years, and is going to add 4.1 trillion to the national debt. All to apparently extend 2017 tax credits that are primarily going to benefit high income earners. Now, there was a strategy to the way our legislators rolled this out. And this is according to one author I read, and it really makes sense. They wrapped up changes in a giant budget bill, and it moved fast through Congress, as you recall. You couldn't really follow it or know what was going on. The changes were wonky, and it was hard to understand them. They're going to be rolled out over time. A lot, not shockingly, after the midterms. So this really is like the frogs in the water where they're turning up the temperature. A lot of folks won't see problems with their health insurance until late next year. The same group of legislators emphasized parts that were popular with the public, like work requirements for the able-bodied. We'll talk about who those able-bodied are in a minute. And then they made it sound noble by claiming waste, fraud, and abuse, and protecting the program for the truly needy. Sound familiar? We saw those guys on the news every night. Well, how many people are going to lose insurance with Medicaid and the ACA? And let me just be clear here. The targets of the One Big Beautiful Bill Act are the Medicaid expansion population and the Affordable Care Act, Obamacare. Those are clearly the two targets, not waste, fraud, and abuse, those programs. So it looks like, and you'll see two sets of figures here on this slide. This slide was actually came out after the Congressional Budget Office put out their June estimates, and then they came out with July with a final score. So the numbers in parentheses are from the final score. But anyway, they're very close. So about 7.8, 7.5 million people going to lose health insurance due to Medicaid changes. Another 2 to 3 million will lose health insurance due to the ACA Act. And then there's this, to make things more complicated, there's this thing called the ACA final rule that I'll talk about. Probably take health insurance from another million people. If that wasn't bad enough, separate from the One Big Beautiful Bill Act, at the end of this year, the ACA enhanced premium tax credits are going to go away. Again, I sound like a broken record. Lack of insurance results in death. When we're looking at medical studies, we call this a major adverse outcome, death, due to simply not having health insurance. And that's from a study by Dr. Adam Gaffney earlier this year. He was former president of PNHP and is now at Harvard. So this has real ramifications. On the left is all the stuff dealing with healthcare in the One Big Beautiful Bill Act. Fortunately for you and me, I'm not going to be talking about everything. I'm going to try and hit the highlights. Again, it's a phased implementation over a number of years. Bottom line, about $911 billion to $1 trillion decrease in federal Medicaid spending over the next decade. Most of that happens in the last 5 years, so we are boiling frogs. And then in addition to the One Big Beautiful Bill Act, the temporary enhanced subsidies are going to expire, and we got this funky marketplace integrity and affordability rule that's going to take another chunk out of insurance. So before we get into what they're going to take away from people, I really want to let you know how important it's been to people to have health insurance through Medicaid expansion, to have health insurance through enhanced premium tax credits. If you're like me and you think insurance and life is important, you'll see just how important these programs are, and then you'll see the damage that's going to be left in the wake of this bill when that coverage is taken away. So Medicaid is a terrific program. It covers about 80 million low-income people in the United States, mostly children, pregnant women, people with disabilities. If you're a nursing facility resident, you're probably on Medicaid. Before Medicaid expansion, before the ACA, adults who weren't pregnant or didn't have children or weren't disabled or elderly really had a difficult time getting Medicaid. And the income limits for Medicaid were very low. So these were folks below 37% of the federal poverty limit in North Carolina, varied from state to state. So that left what we called a coverage gap, where there were a group of people who earned too much money for Medicaid, but too little money for the Affordable Care Act subsidies. And so what the Affordable Care Act did was expand Medicaid to fill that coverage gap so that everybody would have health insurance. So they expanded Medicaid to almost all non-elderly adults. You didn't have to just be pregnant anymore, have children, disabled, all non-elderly adults up to about an income of $21,000. That was supposed to fill the coverage gap. The Supreme Court took the punch bowl away from the party and made it optional in 2012. So to date, only 40 states and the District of Columbia have expanded Medicaid. 2 years ago, Medicaid got expanded in North Carolina. I work at a free clinic. That was one of my happiest days was to see my patients leave the free clinic. Not that we didn't provide free care at the free clinic, but it was not comprehensive. We could diagnose a lot of things, but not treat them. But I had patients who were able to leave there, get Medicaid, and have full, comprehensive, life-saving health care. One of the happiest days of my career as a volunteer physician. This slide's a little busy, but it shows under the umbrella the coverage gap that was filled with Medicaid expansion. People who earn too much for Medicaid, but too little for the marketplace subsidies. So Medicaid expansion was very successful. About 21.3 million people now in the Medicaid expansion group. And again, life-saving, saved about 27,000 lives over 12 years. Last slide on the benefits of Medicaid, and then I'll quit banging this drum. Access to care, health outcomes, financial security, economic mobility. You heard a lot from our legislators about you got to get a job so you can have health care. Well, actually, the converse is true. It is much easier to get and maintain a job if you have access to health care and you're healthy. That increases employability rather than the backwards way Washington has been looking at it. And then, of course, it reduces uncompensated care. Key Medicaid provisions. Pay attention to this first one because this one is particularly stark. Because of the Hyde Amendment, the federal government hasn't paid for abortions or covered them with Medicaid for a number of years. But this first provision in the One Big Beautiful Bill Act was aimed at clinics that provide abortion coverage in addition to family planning, reproductive health, other related medical care. It was primarily aimed at Planned Parenthood, but other clinics for low-income people and medically disadvantaged people called essential community providers. Fortunately, this has been temporarily blocked by a court ruling. This was only going to be in place for a year, but that's enough time to really do some damage. And it was very concerning that 200 Planned Parenthood clinics would close, and as a number of these other community clinics would close, 2 million women would lose access to cancer screenings, contraception, family planning. It's on hold for now, but watch it. In October of 2026, what immigrants can qualify for Medicaid is going to change. Right now, if you're on temporary protected status, you're a refugee or given asylum, you can get Medicaid. In October 2026, it'll only be largely, with a few exceptions, it'll be green card holders, legal permanent residents will get it, not asylum seekers. Then I want to talk about eligibility redeterminations and work requirements. So in December of next year, you're going to have to do an eligibility redetermination every 6 months for expansion beneficiaries. Again, they're the target. And Medicaid work requirements will have to be verified monthly for expansion beneficiaries. One of the ways that states pay their share of Medicaid, and it didn't go into this a lot, but of course, Medicaid's a shared program where the feds pay some and the states pay some. One of the ways the states pay their share is by taxing hospitals and nursing facilities, and that's been limited. So states will no longer be able to pony up their share of Medicaid as they can now. That will result in decreased federal matching funds. And long story short, that threatens expansion. Expansion can go away. And then there's going to be cost sharing for, again, expansion beneficiaries, $35 a visit for them. That's big money for a lot of folks. Let's talk for a minute about Medicaid work and reporting requirements. Yeah, I want to talk about the truth here about work and reporting requirements. And this is really this is settled science. There's a lot of data on this. Reporting requirements are confusing to enrollees, costly and complex, and they're really hard for states to implement. The CBO estimates that work requirements do lower federal spending, but they do it by increasing the number of uninsured. They have no effect on employment. And turns out most Medicaid adults already work in jobs, but those jobs don't offer employer-sponsored insurance. A lot of it's agricultural jobs, things like that. And many Medicaid adults have barriers to employment like transportation or internet. So we've done this experiment already in the States. Arkansas had a work requirement program in 2018, and sure as shooting, 18,000 people lost their health insurance. There was no increased employment. And it was expensive for them to set up that program, just like it is for Georgia. Georgia has a similar program that they're working with now or trying to implement now. Again, access to affordable health insurance and care promotes employment rather than the converse. Okay, so most Medicaid adults under age 65 are already working. let's put this myth to rest. So this is the Medicaid expansion population, about 26 million people, 16.6, almost 17 million people of them are already working. Then you have some that aren't working due to caregiving, have an illness or disability, or not working due to go to school. And then lastly, up in the upper right-hand corner, you have not working due to retirement and inability to find work or other reason, 8% not working. Who are they? Are they really young men living in their parents' basement watching video games because they don't want to work and they were giving them free insurance because they're so lazy? No, of course not. That's just a trope. Let's talk about who they really are. This is a fascinating study that came out from the University of Massachusetts in Boston. It's a census-based study about who this 8% are. Now, 30% of them are able-bodied. They've had work experience. 30% of that 30% are available and are looking for work. The last 70% of the able-bodied, most are middle-aged women. They're not well educated. They're low income. They may have recently left the workforce or been out of the workforce, working as homemakers, taking care of older adults or adult children, and they more than likely live in rural areas. So rural, poorly educated, low income, middle-aged women who are home caretakers. This is all summed up in a quote from one of the authors that I found particularly profound. She said, "We simply cannot afford a Medicaid work mandate that will do nothing to increase employment and only serves to disinsure vulnerable, impoverished, older working age women on whom their families depend." Rural hospitals are going to take it on the chin too. They're already struggling. About 100 have closed over the last 10 years. They have a lot of adults and children with Medicaid. And right now, 300 rural hospitals are at risk of closure, and 190 are in expansion states. So the OBA is going to take 137 billion from them in the next 10 years. One of the last things that was added on at the last minute to the bill was this rural health transformation thing of 50 billion over 5 years. That is clearly not enough. And then there's going to be a lot of uncompensated care because, shockingly, what do sick people without insurance do? They go to the emergency room, and that creates uncompensated care. Let's talk a minute about temporary enhanced subsidies. They're also, to make it more confusing, they're called enhanced premium tax credit. So I talked about kind of the baseline subsidies that the ACA had baked in. Well, but during COVID, it became clear that people needed more access to insurance. So the American Rescue Plan in 2021 put into effect these enhanced subsidies, and that was included through by the Inflation Reduction Act. If they're not extended, they end at the end of this year. And what they do is they really lower premiums for folks, and they put a cap on premiums for folks who earn more than 400% of the federal poverty limit. It saved the average enrollee about $700 and lowered premiums by 32%. And it really helped people of color and lower income people. Here's a graph that shows that graphically, that big upswing with the premium tax credits. It increased enrollment by about 10 million people, and the uninsured rate was at a historic low in 2023 at 8%. That just is music to my ears, but that is the last time we'll see that number. Um, what's the One Big Beautiful Bill Act do to the ACA marketplace? Lots going on here, but basically it's going to make it harder to sign up. There's going to be no automatic re-enrollment. There's going to be shorter enrollment periods, higher out of pocket. This bill really targets Obamacare. They did not like Obamacare. Some low-income legal immigrants will lose their subsidy eligibility. It'll just again be green card holders. And then enhanced premium tax credits going away at the end of this year will increase out-of-pocket premiums 75%. Just a graph that shows the difference between premiums with enhanced premium tax credits in blue versus original premium tax credits. About 4.2 million people, again, will become uninsured with this. And what will happen is young, healthy people like, my kids will say, I'm not going to pay that premium. I'm just going to go naked with no insurance. Of course, that sets what little hair I have on fire to hear that. But as you all know, the way insurance works is you have a risk pool. So you have to have some healthy people and some people with poor health in there. And once healthy people roll off the ACA because of the premiums, that'll change the risk pool. So we're expecting another 18% increase in premiums in 2026 on top of this. So ACA insurance is about to become a lot more expensive. To be clear, we're talking about premiums here. There's already high deductibles in these plans. Medicare is not spared, even though they always told us we're not touching Medicare, we're not touching Medicare. Well, they're touching Medicare for low-income people. It's going to be harder for low-income folks to access the low-income subsidy that helps pay for drugs, and the Medicare savings programs where they use Medicaid to pay for premiums. Many lawfully present immigrants are not going to be eligible. And then you may recall this pay-as-you-go law that it requires that if new legislation increases the deficit, sequestration or across-the-board spending cuts can be triggered. So with Medicare sequestration, if there's no waiver, you can see almost $500 billion in Medicare cuts from 2027 to 2034. So all this is to say, healthcare insecurity was already terrible. 1 in 3 adults right now don't have access to affordable quality health care. That number's been increasing since 2021, particularly for people of color and low-income households. It's about to get a lot worse. So we really came to a fork in the road this last year in our country, and we took a bad turn toward a more cruel outlook for healthcare rather than compassion in the United States. There's worse healthcare coverage ahead for the most vulnerable: women, people of color, low-income person, people living in rural communities, and the elderly, just to name a few. But it's not too late. We don't have to stay on this path. We can raise our voices and speak up for the kind of healthcare we want. In fact, a recent Gallup poll shows most Americans believe that ensuring healthcare coverage is the government's responsibility, 62% of us. Background of this is about more than half the countries in the world have already pledged to protect their citizens' rights to health care, either through law or international agreements. As a nation, we have not codified health care as a human right. But it's clear from this Gallup poll study from last year that most of us believe that we ought to have universal health care. Of course, the disagreement comes in what that looks like and how that's done. And I'm going to show you the way that I think that the Physicians for a National Healthcare Program thinks this is best done. And we think the answer is to provide universal healthcare for everyone, single payer healthcare paid for by the government through taxes, provided through an improved version of Medicare for everyone in the United States. Medicare, we know, is efficient and very popular. It's not perfect, though, so there'll be some improvements to it. It would provide coverage for everyone with no copays, deductibles, or premiums. There'd be no supplemental insurance. It would cover dental, hearing, long-term care, funded through progressive taxation based on income. Patient cost sharing would go away, which is a barrier to care. You would cut out all this administrative cost that we see in our current for-profit commercial healthcare system. We just line them up side by side, commercial insurance and improve Medicare for all. There wouldn't be these narrow networks of hospitals and physicians where your doctor's in network or out of network, and you got to check every year. There wouldn't be any premiums, copays, or deductibles. The prior authorization, the bane of healthcare providers' existence, would go away. We wouldn't link healthcare to your job anymore. People could move between jobs instead of staying at Starbucks for the healthcare. You could start your own coffee shop, and you would have freedom of choice. Any hospital or physician you wanted to go to, lifelong. We call this everybody in, nobody out in PNA when we talk about this at PNHP, and that means everyone residing in the United States, regardless of age, income, employment, or immigration status, would have health care for their entire life. Of course, there'd be no pre-existing conditions. How, how would we pay for it? We're already paying for it. We're paying for single payer healthcare without getting the benefits of it. So this would be paid by taxes, and 95% of households would pay less in taxes than they currently pay in premiums, copays, and prescriptions. It would be cheaper for most Americans, and you'll have full comprehensive coverage free at the point of care. You don't get that copay, you don't get that deductible, you don't get that overly expensive medication at the pharmacy. It's free. How would we pay for it? Well, there's that $650 billion in savings from getting rid of all the administrative bloat that we have with commercial healthcare. New expenses would be about 325 billion. So you can see over there on the right, savings would be about 325 billion. Again, administrative overhead for private insurance companies now is about 18% compared to Medicare's overhead. It's about 2%. So we benefit from the cost savings of a Medicare program. Good news is most Americans, at least in this survey in 2020, support Medicare for all. And of course, most of them are Democrats, less so Republicans, but most young Americans support Medicare for all. And this is a bit dated study, 2017 said most physicians support Medicare for all. So there are two bills now before Congress, the 2025 Medicare for All Acts. There's a congressional bill and a Senate bill. Senate is Bernie Sanders. Congress is Jayapal and Dingell. They are essentially the same as the 2023 version. So if you scan these QR codes, if you want the quick and dirty fact sheet, that's great. It's going to be the 2023 Medicare for All Act, but it's the same information that you would find in an analysis of the 2025 Act. And then if you want to take a deeper dive into these bills, you can scan the QR code that's below that. So that's what we hope to see, and that's what we're advocating for. So find out more about it, and please take a look at PNHP. Thank you.
All right, well, I know there are questions in the chat. Julie's furiously writing, so I'm going to spotlight her, and if you want to take the slides down, and we'll get to the Q&A.
Well, we have had a lot of interesting questions, comments, and the like in the chat. One thing I wanted to say, somebody has ambulance bill. Ambulance bills are usually always out of network, but sometimes your insurance company will pay for it anyway, but you have to go through a third party that makes them do it. So call your insurance company and ask them if that's the case with yours. Just wanted to give that little nugget.
Yeah,
I had to
the
fight
No
to get mine
Surprises
done.
bill covered. Yeah, the No Surprises bill oddly covered air ambulance, but not ground ambulance. So I don't know
Right.
why they did that.
Well, I was shocked because I work for a government, and so they have decent coverage, and I got an $1,100 bill, and I'm like, why? I have 100% ambulance coverage, and we're out of network. So where is this bill coming from? And that was because the insurance company wanted to pay a negotiated rate, and they don't have a negotiation with anyone, and so I had to fight them to get the rest of the money paid, but it did work. But I know that that's not the case for everybody, but just a little nugget for everybody. So someone asked where your stats and things came from that you had on your slides.
Yeah, so most and I was not particularly good about annotating where they came from there, but most are from two sources: the Kaiser Family Foundation, which has a lot of data about health insurance and healthcare in the One Big Beautiful Bill Act. So if you just Google KFF and the One Big Beautiful Bill Act or health insurance, and the other one is a group called the Commonwealth Fund. which has recently done an analysis of insurance in America. So those two groups, Commonwealth Fund and Kaiser Family Foundation.
Okay. And then someone asked if insurance companies are using AI to make coverage decisions these days.
Well, that's apparently a problem, and Congress is looking at that. But yes, so there has been some talk of that. It is hard being a healthcare provider these days because a lot of these insurance companies at first say no to things because they delay care, they deny care. I forget how many million hours Americans spend each week trying to talk to their health insurance companies. Cancer patients, probably 25% of the time, have delays in their care due to health insurance. But there has been some talk of them using AI, and I think our legislators are looking into having some guardrails around that.
I spent the first 25 years of my working career as a follow-up medical biller. So I was the one when the bill got denied that would call the insurance and get the bills paid. I was actually quite good at it. So
People
I
are
know that that is
successful. I
true.
mean, yeah, people, you can be successful if you ask
Mhm,
it, but you have to persevere.
mhm.
There's a book out there called Never Pay the First Bill. So I didn't want to mention because it doesn't sound like a good idea. Never pay the first bill, and you can um, do that.
Mhm. Um, so how can we effectively argue, for this plan that, you have or, showed us this evening in this climate that we're currently in, someone asked.
Well, that's a challenge.
Mhm.
And I think, like any conversation we have with people who might not agree with us, I like to start with something we do agree with. So when I talk to um, my friends from the other party, I talk to them about they're against waste, they're against fraud, they're against abuse. Unfortunately, a lot of that goes on in commercial health insurance. There's a tremendous amount of waste and overbilling in commercial health insurance. I didn't even talk about Medicare Advantage, which is a commercial version of Medicare in which there's a lot of waste and abuse. So if we talk about that, then if I talk to my Republican friends who are small business owners, most of them don't want to be in the healthcare business, but they are. They have to negotiate healthcare for their employees, and
Mhm.
so I don't think most business owners want to do that. So I try to talk to people about issues that affect them. We're Americans and we love choice, so we'll always die on the hill of choice. But I want choice in my healthcare. Choice in American healthcare is an illusion. It isn't. We have very little choice in healthcare.
Especially when you talk about an emergent situation, you have no choice. When you go to the hospital, you don't get to choose who you see. You see who's there, and you're glad to see them because you're
Right.
sick.
That's
There was a lot of chatter and discussion in the um, in here in the chat because people did bring up Medicare Advantage and is it unscrupulous? And then there was talk of Kaiser Medicare, and someone asked about Humana. So all of those things are actually first and foremost on quite a few folks' mind in on this call tonight. Um, any
We saw a lot of that last year. It was terrible. Brian Thompson, CEO of United Healthcare, was assassinated. Um, and instead of a public outcry of mourning his loss, you heard a public outcry against commercial health insurance. Um, because of cost and delays and denials of care. Um, Medicare Advantage costs the government billions of dollars more than Medicare does, and a lot of it is fraudulent. They do something that's called upcoding, where they add diagnoses to people to make them look sicker so that they can get more Medicare funding. There's a number of other issues. But unfortunately, Medicare Advantage is on the rise. It is now probably 60% of people with Medicare have Advantage plans. Most of you talk to your friends who are on Medicare, most don't know what they're getting, right? Medicare Advantage can be great insurance if you're not sick. Unfortunately, if you're sick, it's not very good insurance. That you have narrow networks where you can't go to specialty oncology hospitals if you want to. You have, again, talking about choice, there's very little choice for people once they are ill in Medicare Advantage. So they're lured in with eyeglasses and gym memberships and these advertisements that show healthy seniors. But we're all kind of pre-sick. We're all going to get sick someday. And when you do, Medicare Advantage care is not as good as traditional Medicare, I would dare say. That is not to say I don't want to give anyone buyer's remorse who has Medicare Advantage. There are some good Medicare Advantage companies and plans out there, but there are some unscrupulous, overly costly ones as well.
Mhm. You had mentioned not paying medical bills with credit cards, and someone just wanted kind of like a why, why not? If
Yeah,
you,
because then it becomes credit card debt instead of medical debt. And
Mhm.
that puts you in a different category when hospitals, if you get your hospital to negotiate your bill and you've already paid for it with a credit card, well, the hospital's already gotten their money,
Mhm.
through the credit card, and you're paying the credit card percentage. It makes it more difficult for you to get charity care. It just puts that debt in. Remember how I said how medical debt is of a different flavor than regular credit card debt or other debts
Mhm.
because it's emergency debt. It takes you out of that class and just puts you in regular old credit card debt, like people who run up their credit cards on everything.
Mhm.
It's no longer distinguished as medical debt.
So, what are good arguments for a universal healthcare system? What's some, nuggets that folks can take away from this tonight?
It is less expensive. We save money from doing it. We save lives from doing it. Economically, it spurs entrepreneurism. So um, people uh, tend to start their own businesses more if they don't have to worry about healthcare.
Mhm.
Employers don't have to worry about healthcare anymore. They can pay their employees more. So this is good for labor unions. Um, and, and, um, and we can do it. We are already paying money like they do in other countries that have universal health care. And we would have that. I can't help but think that we would have better statistics. If you look at longevity in the United States, when people reach age 65, longevity goes up. Why is that? Because everybody gets Medicare. Before that, our lifespan estimate is lower because a bunch of us don't have health care. So everyone having health care saves lives uh, and increases lifespan. It's good for the economy. Um, it's good for people.
I had the privilege of seeing Reverend Barber, um, Reverend,
Yes.
on last Friday. And he actually said, and I think it's a combination of all the other things that you didn't, of course, it didn't need to cover about the horrible bill. Um, he said 31,000 people per year will die from that bill. So just wanted to kind of, I know you said 17, but I think that was because of the medical part of it. But I think there's other
17 was just
aspects.
Medicaid. 17 was Medicaid.
Yeah. So,
Yeah.
so just
And
so
then
that
there was
people know that that's really going to be
yeah,
devastating to all of us because that's a lot of people. Um,
yeah. People
so,
die with it. Now, I was a diabetes doctor, so I saw it firsthand
Mhm.
when people would lose their health insurance. If you have type 1 diabetes and you die without insulin and you lose your health insurance, it's a scramble to get coverage because without that drug, you die. And I would see people scramble and do their best, cutting test strips in half to do finger sticks. It shouldn't be like that in America. We're the wealthiest country in the world. It's
Mhm.
horrible.
It is, it's awful. So folks wanted to know how you counter, they have MAGA legislators. So who say that Medicaid isn't going to be cut, which clearly is not true. So how do they counter that?
Well, I think to me, the real revelation against this, I mean, every night we'd hear, and I probably watch the news far too much. When you're retired, you really don't want to watch the news. It's too much. But every night you'd hear them talking about, we're not cutting Medicaid, we're just preserving it for the people who deserve it. The original Medicaid group, pregnant women, children, the disabled, the elderly, they do not think that other people in the Medicaid gap should have health insurance because they're not working. They're living in their parents' basement. They're able-bodied. Well, we showed you that most of them are working. Many are working in jobs that don't provide health insurance, service industry, agriculture. And then if you really drill down on it, the very few percent that aren't working are they're middle-aged women who may have been in the workforce but have moved out of the workforce. They're near retirement age. So it's a lie. They created this trope. Remember Reagan's welfare queen? They
Mhm.
essentially redid the welfare queen, but made him a guy living in the parents' basement who's taking your Medicaid dollars. And they'd say every time, who could be against that? Most Americans are for work. Isn't work good? Don't you want to work? Um, uh, I am for insurance for everyone. It saves lives. It improves lives. It's good for the economy. It saves money. It spurs entrepreneurism. Why wouldn't we want to do that? It would be different if our statistics were so great and said, we're doing great. We're not. We're doing terribly. Our health statistics for longevity, uh, Black maternal health is, white maternal health is doing terribly. Black maternal health, three times the mortality of white women. We're at the bottom of the barrel in a lot of these healthcare statistics.
Yeah, it's awful. It's awful. And it's how I actually lost my mom. So I totally know this. What is parting words that you would want to give to us this evening? What would you want us to do immediately? What's something that folks can do?
Um, I think first, when I had that sign up that showed us going one of two different ways, just think, what kind of country do I want to live in?
Mhm.
Do I want to live in a country of compassion or a country of cruelty? And by compassion, I just don't mean giving things away willy-nilly. But I believe healthcare is a human right, as do most faith uh, yeah, and faiths and religions. So far, if we start with that, healthcare is a human right, and then build on that. How do we deliver it? At PNHP, we think we ought to keep the fox out of the hen house. Commercial health insurance that overbills and overcharges. We've seen how letting that fox in the hen house has really threatened Medicare with Medicare Advantage. So we are firm believers in we already have Medicare in front of us that works very well. We make it better, we expand it, and we can have universal health care. We can save lives um, and make America a better, more compassionate place for all of us.
Okay. Well, I want to thank you for coming and sharing with us. I know Julie will be sending out a email to follow up from today's presentation, and I'm going to kick it back over to her.
Thank you again. We really appreciate your time, Dr. Robinson. It was very informative. A lot of information, but very informative, and the slides will be helpful. So, all right, everybody have a really great evening. We'll talk to you soon.
Thank you.
Bye.